Hello, nice to see you again. I'm Lenka Laubrová-Žirovnická from the Association for Freestanding Birth Centers and Alongside Midwifery Units. And I welcome here today the co-founder of the Midwifery Unit Network, Dr. Lucia Roca Iheanacho, who serves us as a great inspiration and successful advocacy model of MUNET is really what we strive for. Hello, nice to see you again.
Hi, Lenka. Lovely being with you.
Could you please, Lucia, tell us more about birth centers as such, about the model of care within the birth centers, and let's call them non-negotiable elements that are within this model of care needed to be within the European standards of care within MU units?
Sure. So I think we can start really with the definition of a midwifery unit because pretty much summarizes the key elements. So midwifery units is a maternity unit dedicated to women who are healthy and have physiological pregnancies, and they are run and led by midwives. And it's very important to understand how these are organized and the model of care. Because, of course, this is part of the non-negotiable pillars of what defines a midwifery unit. So number one, they need to be a separate unit from the obstetric unit. So they need to be, have in its own right a maternity unit. And of course, what makes a difference compared to the obstetric unit is the fact that they are dedicated to women in a physiological situation. And generally, there is a lot of attention to the environment to be user-friendly, so they would look more like a hotel than a clinical setting. And they are also inspired by the biopsychosocial philosophy of care, which really caters for the biological, psychological, and social needs. We could also say spiritual needs of the women and the service users. So, for instance, there is attention when you walk into the unit for it to be in a relaxed setting where there is maybe, tables and chairs and sofas, and people are instantly relaxed by entering that space. There isn't a net division between staff and service users. So, for example, another important element is generally midwives in birth centers or midwifery units, they don't wear uniforms. They tend to wear normal clothes to really break down that barrier between us and them. And also spaces are normally shared. So there are very few spaces which are just for staff. Of course, you will have a clinical room or where we have confidential information. But for example, when you walk in and there is this kind of reception, is more like a lounge with sofas and chairs. And maybe there is a kitchen that is open to everyone to use. So a service user could walk in and wait for an appointment and walk in the kitchen and make themselves a cup of tea and interact with others. So there is that kind of vibe. The second element is that they are run and led by midwives. And this is another very important element because we now have very robust evidence suggesting that midwifery units have better outcomes, of course, we're talking about a population of healthy women, compared to the obstetric unit. So compared to having all women of mixed, let's say, risk factors in the obstetric unit, there are huge advantages in having a dedicated unit for women in physiological situations because they are looked after in a more relaxed manner. There can be more relaxations about time frame around labor and many other aspects. So when you have this midwife-led model of care, which means you have the midwives providing one-to-one care in labor, but not only, generally, we also aim to have continuity of care during pregnancy and childbirth in general. So which means you will have women looked after already antenatally by a very small group of midwives. And then those same midwives will be there for labor and birth. And those same midwives will also look after the woman postnatally. Generally speaking, the postnatal stay at the center is shorter compared to a hospital, but then there is a follow-up at home, right? Because there is something special and also not only special in terms of experience, but in enhancing really safety. The fact that you see the woman and the family within their own setting, you can pick up very quickly if there's something not right in maybe mother, mental health, issues with domestic violence and various other stuff going on. There is special for you, for a health professional to be really entering that kind of private space of the family. So within this model, of course, you need to have enough staffing, so enough midwives to be able to provide one-to-one care and continue support in labor, which we know is one of the biggest evidence we have in terms of improving outcomes and experiences and cost effectiveness. What else? And of course, we are still part of a multidisciplinary team. So it doesn't mean that, as midwives, we're working in isolation, but you are working within those boundaries of physiology, which means that when things remain normal and physiological, the midwife will take care of the woman for the whole period of labor and birth and postnatally. And when there is any complication arising, then there is a escalation process and transfer process. And we are always in contact with our colleagues on the labor ward, with the obstetricians, with the neonatologists. And we know this actually is the ideal model. And why is that? Because you maximize that physiological aspect, but also our colleagues who need to look after women who have a lot of complications and pathology, they also have more time to look after those women, because those women who have complexity also deserve to have the best care. And very often in a labor ward where you have low-risk women with lots of complications, thing gets mixed up, and no one gets the best care, right? Everyone misses out. So I think that's the second aspect. The third aspect is the autonomy of the woman. So really understanding, number one, how physiology works and how to support it. But number two, the human rights of women and their right to dignity and respect and being able to make choices around their care, which, means that sometimes these women and service users may make choices we don't agree with, right? But they are adults and they can make their own choices. And our job is to provide the information about the pros and cons of different options. And ultimately, those making the decision is not us, but is the service users, the woman giving birth, right? So does this help understanding the key pillars? I'm thinking if there is anything else I left out. So I would say the environment, the model of care, which is linked with the one-to-one care and the continuity, the autonomy of the midwife, working in partnership with the multidisciplinary team, and the autonomy of the woman. I would say those are really the key pillars.
Yeah, and also it was interesting to hear that there is a huge continuity in the process, like antenatally and postnatally, and that the postnatal care occurs within the households of the service clients. So that's something pretty new, or let's say it's a renewal of something we used to have 50 years ago. Yes. And we're now trying to get it back. So thank you very much. And I would also like to address what are the barriers and challenges that we might encounter in our process of establishing this new model of care. What do you think? Can you elaborate on this?
Well, so generally speaking, there are quite lots of barriers. If we focus on, let's say, across Europe, there are quite a few barriers because generally speaking, there is variability between countries. But there hasn't been a move towards what we call medical industrial model of care. So big obstetric units led by medics and not really focusing on the needs of the service users, right? So these obstetric units have been designed following Fordist and Taylorist principles. So basically similar to how to run an efficient factory with an assembly line process. Problem is women are not packages and that simply doesn't work. And also midwives and health professionals are not factory workers. I mean, I'm pretty sure that system doesn't work for the factory workers there either in terms of their satisfaction and mental health, but really in healthcare, it doesn't work. So when you start thinking about healthcare, right, means care, means giving time to people. But when you start having to demonstrate every minute you spend with the person you're looking after, that is actually caring now is conceived as doing something to someone, okay? But actually care sometimes simply means sitting there and supporting someone and listening to them and encouraging them, right? And this is not seen as care anymore. It's crazy, right? So we have moved, you can really see with the young midwives and professionals, if you take them, in a birth center, they need to sit in a corner and observe. They become very anxious because they feel like they need to do something, right? And in fact, for childbirth, when everything goes well, there is this, this caring means sometimes just sitting there and observing and listening and fine-tuning with what's going on. And just by listening to what's happening, how the woman breathes, the noises she makes, we know what's happening, right? And is a way of assessing the progress of labor. And it's very important for new generations to learn that art of midwifery that is been lost, really. And so all of this, is quite problematic if the new generations are only learning to do interventions and do things, and they're really missing out in the key core aspects of what that care means. So really it's about moving away from that system. And so the barriers really are going back to the philosophy of care that has been mixed up and lost. Also the hierarchies and the cultures within healthcare settings, which have basically created this hierarchy between midwives and obstetricians or midwives and anatologists, which is very problematic. And of course, you need to go back to sociological and cultural aspects, unfortunately. And those to eradicate are really difficult because you need to, it needs to be planned strategically how to change this. But also, again, culturally, in terms of, where is the position of the woman in all of this, in terms of power? Yeah, so we get issues with hierarchy, with patriarchy, with misogyny, all those lovely ingredients which are really hard to tackle. So I'm afraid it's not an easy job, but by already identifying where the barriers are, so doing what we say context analysis in terms of your country, your setting, is very important. So you're going to have to tackle a certain number of barriers. And then, of course, there are kind of more specific barriers to do with the health system. So how is the funding allocated? What is legislation around birth? So these, for example, determines whether freestanding birth centers are legal or not, because in some countries, as I guess still Czech Republic, unless it has changed recently, there were legislations limiting the freedom of assisting birth outside a hospital. But also in terms of the autonomy of the midwife, is a midwife able to practice autonomously? And sometimes actually, in fact, for sure, across the EU countries, there is a legislation that defines what a midwife does and the autonomy. So, legally, midwives are able to provide autonomous care, but then often there are barriers at institutional level within the organization. So, for example, a hospital determines that the head of the department is always a doctor. And then you have this hierarchy for which, and on a shift, the person in charge is the doctor. So, of course, in order to break this barrier, you need to change that system, because otherwise you will keep fighting against someone saying, well, I'm not taking responsibility for the other person to assist the birth, because then if something happens, I'm responsible. So you really need to go back. And what I always suggest to do is do a mapping of, so from one side, what you want to happen, from the other side, what are the barriers and facilitators, and then start creating a strategy on how to tackle each one of the barriers. There are many, but I think including and involving all the stakeholders who are, who have a say on this matter is very important, to bring them, on this journey with yourself and convincing them, and always try to think, okay, the politician, what does a politician have to gain from implementing a birth center? Well, they can use it in their political campaigns to say they're doing stuff for women and children. And what about a hospital manager? Well, the hospital manager if they implement midwifery units, the hospital will be more efficient, have better outcomes, and save money, and have better experiences and outcomes as well. Also, they will retain staff more because midwives and obstetricians will be happier. So it's all about showing people and telling them the things they may want to hear that meet some of their needs. So it's never easy. And we are developing with Immunet a tool to assess organization readiness of a maternity unit before they even plan to implement a birth center. Because what we have realized is that people are not really used to this idea of understanding what these barriers are. So we are going to provide this tool that is going to help units. And then even before they start planning, they can start working on how to improve things.
Okay. Allow me, Dr. Lucia, allow me last question. I would like to ask you about hybrid model of care, as we have seen across Europe that there were attempts that were not in accordance with the European standards. Yeah. You, Immunet, provided, and it was not actually an evolution towards a midwifery-led autonomous care. Would you please tell us more about this mixed model of care and its success or non-success within Europe?
Okay. Right. So in implementation science, we have two principles. We have the principle of fidelity and the principle of adaptation, right? And they are kind of the opposite spectrum. So fidelity is you have a recipe of the ABCs of how you do something, and you do exactly the same way it has been written. And the adaptation is all those modifications you do because of certain needs of the context, right? So we can apply that same principles to midwifery units. But before we do that, it's important to understand, are these elements of adaptation proposed because of certain specific needs of the settings, or are these done because they are shortcuts, because people don't want or are unable to overcome some of the barriers? This is the question that people need to ask, number one. Number two, they need to ask, if we do any of these adaptations, what are the unintended consequences? Because very often you do something and you don't know what the result is going to be, okay? So for example, having CTGs in midwifery units, right? CTGs should not be midwifery units because that's not midwife-led care. And if you start introducing them, you don't really know where this is going to bring you. And I would suggest actually care will be less safe because you're introducing elements that might reassure you from one side and you may delay transfer, for example, okay? So this is very important to discuss and never introduce those alterations as a shortcut, but really do the legwork and really do, speak to those who have done it before, who can tell you, look, we tried that, doesn't work. So generally speaking, I would always recommend to try to stick to the fidelity as much as you can. And if there is any element that you want to change, reach out to us. We can have a call, we can have a chat, and we're more than happy to tell you what is the experience. The experience in general is when there have been those shortcuts, it has not been successful, okay? Because what you do is you go and jeopardize the sustainability of the model, right? And then it's a pity because there has been so much work done, and then unfortunately the project is not going to be successful.
Thank you very much. So again, thanks for your ongoing efforts of Immunet to educate both healthcare professionals and the public about the benefits of IMVUES. We will be trying to do the same here in Czech Republic, and see you next time with the next webinar session. Thank you very much.
Bye.
Bye.